Well, let's go ahead and get started. Thank you, everybody, and welcome. I'm Kim Bischoff, the Executive Director of the Neurofibromatosis Network, and we are grateful that you're joining us tonight for our webinar. The NF Network was established in 1988 by a group of individuals that were affected by NF. Our organization consists of state and regional member organizations that come and unite on national issues. The NF Network is formed on three different pillars: our Heartline, which supports our NF families and individuals; our NF Network Advocacy Program. This is our flagship program. It's where we go to Washington, D.C., and we advocate for federal funding for NF research; and our new program, Project Dream, where we invest in seed research grants with collaboration from our Scientific Advisory Committee. So tonight, we're very fortunate to have Dr. John Henson, who comes to us from Augusta, where he is affiliated with WellStar Oncology. Dr. Henson is also a professor of medicine, neurology, and neurosurgery at Augusta University. We're happy to have Dr. Henson with us tonight as he explores the role of genetic testing in NF1, and he'll delve into its possible uses for family planning and the advantages of pre-implantation testing. Welcome, Dr. Henson. Thank you for joining us tonight.
Well, thank you very much. It's good to be here, and good evening, everyone, from balmy Augusta, Georgia. In case we have people from colder climes, it's 68 degrees here this evening, and I just had dinner outside in a restaurant, so I hope that's not bad news or painful for anyone else. But it is very nice here in Augusta. What we're going to do tonight is to briefly review some of the major manifestations of neurofibromatosis type 1. And I suspect none of this will be news to the folks on this webinar, because you're here because you're interested for one reason or another in NF1. And then secondly, we're going to go into a hypothetical family structure to look at some of the genetic issues that occur in families with this disorder, and then we'll talk about how to manage those families. So, to get started, one of the most common manifestations of neurofibromatosis type 1 is the cafe au lait spot. And hopefully all of you can see my pointer here, but I'm circling here a typical NF1 spot. These are interesting because they're often the first manifestation of NF1 in a newborn, whereas some of the other common manifestations, such as these cutaneous nerve tumors called cutaneous neurofibromas, those appear starting sometime typically at puberty or thereafter, and then accumulate over time. By comparison, the cafe au lait spots do not increase their number significantly over time. In fact, they often fade and become less conspicuous, while the cutaneous burden of the tumors shown here and here, while those are going up, the cafe au lait spots become less noticeable. Other important cutaneous features of this syndrome are axillary freckling. And in fact, the freckles occur in any place where skin surfaces touch each other. Medical term, we have a really fancy term for that in medicine called intertriginous areas. And so they would occur, for instance, in the axilla, the skin of the axilla, and perhaps at any skin folds in the abdomen or the groin, for example. And we don't know exactly why that happens, but it is a very interesting feature of NF1. And again, it's one of those things where if there's a question about a new diagnosis, or does my family member have this, those are examples of features that we look for. Another very common one, which I don't have a photo here this evening, is the so-called Lish nodule. Lish nodules are little brown spots, little raised brown spots on the colored part of the eye called the iris. And interestingly enough, the presence of a little brown spot on the iris is not clear evidence of neurofibromatosis type 1, because many individuals without NF1 have these little brown spots on the iris. But the difference is that in the little brown macules or flat spots, those are completely flat, whereas the Lish nodule is raised. It's a bump on the iris. And one of the interesting tricks about that is that when a physician looks at a patient's eye with a regular bedside ophthalmoscope, you can't actually distinguish between a Lish nodule and a melanocytic macule of the eye. Only an eye specialist with the slit lamp, we say, as the name of the instrument, can determine that it's actually raised. So, again, as an isolated feature, we wouldn't necessarily be able to say that little spots on the iris in a doctor's office that's not an ophthalmologist would be clear evidence, certainly not standalone evidence. So that's the Lish nodule. They have absolutely no medical implications for vision. It's just a very common feature. In the middle picture here, you can see a rather marked example of a plexiform neurofibroma. This is the hand. You can see the fingers here. And this is one of my patients. And we basically see this large, soft, fleshy tumor. All of you are familiar with these, of course. Um, Certainly not every patient with NF1 has a tumor like this, but they can occur in the limbs. They can occur down deep in the body. For example, it's common to see this plexiform type of neurofibroma, plexiform meaning multiple nodules of tumors. And they tend to occur along the nerves coming out of the neck, going out to the arms, and the nerves coming out of the lower part of the spine, going out to the legs and the bowel and bladder. And those are common places for these tumors to show up. The plexiform neurofibromas are very important in this disease. Number one, they can cause pain, weakness, or numbness. And in addition to that, they can be very disfiguring. So you can imagine that this patient, when she came to see me, had her arm hidden in a sleeve, and only her fingers were showing. And of course, that's simply because this is something that's not easy for her or other people to look at. So we removed that, and with plastic surgery, we were able to restore her arm to a much more normal appearance. And there was no increase. So she had a little bit of weakness in her hand. There was not an increase in weakness postoperatively, for which we were very thankful. I'll come back in a moment to another important part of the disease with these plexiform neurofibromas, but to show you a couple of other typical tumors. This is an MRI scan through the chest, and what you can see here is it's sort of like a cut, as if we just sort of sawed the body open to look at it with the MRI scan, axially, we say, transverse. And what you can see are the lungs here. This is the individual's back. Here's the bone of the vertebral column. This is the spinal cord sitting within the spinal fluid space inside the spinal canal. And you can see that there's a large tumor growing off the spinal nerve root. So what I'm outlining here is the tumor. It's coming off one of the nerve roots off the spinal cord. And this is all a single neurofibroma. Multiple neurofibromas. This is a single lesion. And the risk of this tumor, of course, would be is that if it grows into the spinal canal and begins to press on the spinal cord, that can result in spinal cord dysfunction, leg weakness, bowel and bladder problems. We have many, many patients who face that issue. We go in and resect these. That's the most common way of dealing with those. So again, this is cutaneous neurofibroma, plexiform neurofibroma of the limb, and a solitary single neurofibroma along the spinal nerve root. Here's another very interesting manifestation of NF1. This is a MRI scan and a sort of another horizontal cut, if you will, through the optic nerves. And so this is very intuitive. You can see that's the left eye, the right eye. It's backwards from what you would think, the way it's displayed in the scan. And you can see the lens in the eyeball. And this is the normal side over here, relatively normal. Actually, there's a tiny tumor in this optic nerve, but more notably is the optic nerve glioma in the left optic nerve. So you can see the nerve kind of coming along here, and then this tumor shows up, and it's pressing the eyeball out a little bit. As you can tell, this one is a little bit more protuberant than normal. as seen on the other side. So these optic nerve gliomas, particularly when they're bilateral, that's a tumor, and you have to take my word for it. That is also a much smaller tumor on the other side. When bilateral, that is a classic feature of neurofibromatosis type 1. And many times, patients don't have symptoms from that. And oftentimes around the time of puberty or so, these tumors oddly begin to regress on their own. If they do need treatment, we typically treat that with a combination of medications called carboplatin and vincristine. So down here is yet another manifestation of NF1. And to sort of go through this abnormality, you can see that on the right side of the patient's head, again, remember that MRI images, all medical images are displayed backwards just to try to confuse people. But what we see is a relatively normal right side of the brain, and this little black line right along in here is the bone. And that bone did not form on the left side of the patient's head. We call this sphenoid wing dysplasia. Dysplasia simply means the bone didn't form normally. And when this bone doesn't form normally, the brain tissue doesn't take its normal shape, as is seen on this side. And you can see that this is all the spinal fluid is pushing out into the orbit where the eyeball is. This is a little bit of the eyeball up here. This is all tumor. This is tumor. And this is an area where the brain has sort of been able to pouch out, if you will, because of the absence of the skull. It simply doesn't form. And again, these are all very typical features. This we try to leave this alone unless it's really causing some severe problem for the patient. Then the last thing I want to go through before we get to the family part of this is this example over here. So this is a patient of mine who had some pain in the right groin. And upon imaging, we knew that he had neurofibromatosis type 1. And upon imaging, the MRI scan showed this lesion. So what we have here is the back. This is the patient's back. This is the vertebral body of the spinal column. These are the big muscles that hold our spine straight, give us strength for the axial skeleton. And then this is a large plexiform neurofibroma over here. And it's got some interesting features because typically the neurofibromas show this brightening after contrast enhancement. We call that, after contrast administration, we call that enhancement. It shows this enhancement pattern all the way across the lesion. And when you see the central part that's not enhancing, then the concern here is that this is a tumor that's outgrown its blood supply and is potentially indicative of perhaps the most serious manifestation of NF1, which is a malignant peripheral nerve sheath tumor. So a small percentage of these type tumors will become malignant over time. And in essence, we think of them as acting like sarcomas. This is an interesting comparison scan showing a glucose metabolism study. This is called a PET scan. I think everybody knows what those are. This is glucose metabolism showing that there's very high metabolic activity in this rim, and then this central dead part, of course, doesn't have metabolic activity. And so that was removed, and indeed that lesion was removed by a surgeon, and indeed that was a malignant peripheral nerve sheath tumor. And that is a potentially very serious complication, one of the things that we watch for carefully in individuals with NF1. So basically what I've tried to do here is just to take these images and give you a brief overview, a reminder overview of all of the different kinds of things that can happen. There are other problems that show up with NF1, but these are some of the more important ones. So what
I'd like to just jump in for a second.
Yes.
Uh, there is a question in the chat, and I'm going to ask this one question to you.
Let's take the questions as they come. I would much prefer to do it that way than to take them at the end.
Okay. We will, as long as we have time. Otherwise, we'll push some to the end. But this one here is, can you discuss the risk of passing on neurofibromatosis in a pregnancy if the parent is mosaic?
Yes, I certainly can do that. And we will just remind me to cover that in this slide, because as you can see, we're going to get right into this topic of heredity with NF. So I don't demonstrate mosaicism on this slide, but I will go into that in a little bit of detail to answer that question. Okay?
Thank you.
So let's discuss the non-mosaic, and I'll talk about that separately and kind of define what mosaicism is so everybody can understand that. But let's talk a little bit about the way NF1 is inherited or it arises and can be inherited. And that will lead us to some topics around how we can manage that risk, et cetera, et cetera. So this is a hypothetical family tree. We call this a pedigree. We take these on all patients that come into the center. We also do genetic testing on at least one family member of every family so that we know what the mutation is. That's very important. And so what we have here, males are squares, no surprise there, huh? And the females are circles. So this is a man and a woman who had 3 children. Interestingly enough, neither the father nor the mother had manifestations of NF1. NF1 is in this boy, their son, and that is the blue. The blue coloring here indicates the presence of NF1. So no NF1, NF1. And what we see here is that there's this boy with NF1, and the boy has 2 sisters who do not have signs of NF1. So this is the first issue that I want to cover briefly in this discussion, and that is that in fully 50% of cases of neurofibromatosis type 1, the individual that comes to see you with the problem is the first person in their family to have the condition. And let me talk a little bit about how that happens. But the other thing to say is that we know the genetics of this individual. We know exactly what the DNA change is that led to the NF1 mutation. We know what the NF1 mutation is. And we could go and test the parents and demonstrate that they don't have that mutation. But this is an important concept, this next part. It's called penetrance. And penetrance is a genetic term that refers to the fact that if you have the presence of a mutation in your cells, you are likely to show the manifestation of the disease. In NF1, the penetrance, we say, approaches 100%. So it's very unusual for a family member to inherit the mutation and not show those signs that we went through on the prior slide. So theoretically, the best thing to do here is to test mom and dad. And but they show no signs. If we were to test them, we would expect both of their genetic tests to not show the mutation that their son has. And that makes him a new or de novo case. And again, fully 50% of individuals with NF1 are the first lucky person in their family to come down with the condition. And that's extremely common amongst genetic disorders. It's one of the most common types of new mutation. We think in part that's because the NF1 gene is very, very large. And if you just take random mutations that occur in all of and all across our DNA, the NF1 gene perhaps is somewhat more likely to be the target of one of those, or to be affected by one of those mutations. So de novo case in this man, he's got evidence of neurofibromatosis type 1, features maybe cafe au lait spots at birth, et cetera. He then, and so just to back up a little bit, given that the parents don't have NF1, we would not expect either of his siblings to have NF1, because it's a new mutation in him. It turns out that when you actually do an analysis of where these mutations come from, most commonly they come from a mutation in one sperm rather than from one egg. And so his father would have no manifestations of the disease, mom wouldn't either, and these 2 siblings, these 2 girls, his sisters, if we did genetic testing on them, they wouldn't have the mutation and they would show no clinical signs of NF1. So here we have this patient who's de novo, a new case, and he has 3 children. He has 2 boys and a girl. And two of his children at birth show manifestations of NF1. So the way that this works is that everybody in every cell in the body except for red blood cells has two NF1 genes. One's derived from dad, one from mom. And the problem in NF1 is that you have a mutation in one of the two genes. And that mutation is, so it's a mutation and a normal copy. And the mutation is present in every cell in the patient's body. They also have one normal copy in every cell. Then it turns out that when the second copy, the normal copy, sustains a mutation, typically through random mutations like what happened to cause him to be a de novo case. When that second mutation occurs, and that mutation occurs in a nerve cell, then that nerve cell develops into a tumor. Important concept here, because you have to be able to knock out each tumor in the patient's body has got the hereditary, the mutation that's present throughout the body. And there's a second mutation to inactivate the other second copy of the NF1 gene. And so the way the heredity happens then is that this man, when he has these three children, each one of these kids has a 50-50 chance of either getting his abnormal copy or his normal copy. And so in this case, this boy got a normal copy from him and a normal copy from his wife. In this case, this boy got one abnormal copy from dad, and this girl got an abnormal copy from dad as well. And both of them then go on to show signs of neurofibromatosis type 1. Now, in the next generation, what we show here is that this man then goes on to have children. And of course, it's very unlikely that his wife would be affected with NF1 as well. But what we see is that he's got the mutation. He then develops the signs of NF1, and they have a daughter. She has a 50-50 chance of getting his mutant copy, and indeed she does, and develops signs of NF1. Now, the next question becomes then what happens if they have another child? And so if they decide to have another child, that child has a 50-50 chance of inheriting an F1. And what I want to talk a little bit about is how we can help families have biological children that are unlikely to have that mutation passed on to them. We want to be able to reduce the risk from 50% down to about 5%. And so there are technical ways to do that, and that's what we're going to discuss next. Now, on occasion, when an individual like this develops an F1, and this is getting back to that question about mosaicism, it's not every cell in the body. So what happens with mosaicism is the sperm and egg form the first cell called the zygote, and the two NF1 genes are normal in this particular scenario. Then there are two cells, then there are four cells, and at maybe the four-cell stage, one of the four cells gets a mutation by chance in the NF1 gene, and now 25% of the cells in that patient's body contain a mutation in the NF1 gene. And so then the question is, well, what's the likelihood if this individual has 25% of their cells, it's a boy, so it's going to be, theoretically, his sperm would have 25% of his sperm would have a mutation. And then what's the risk of passing that on to his children? In many cases, it actually turns out that the germ cells, like the sperm and the eggs, don't mirror that 25% chance so closely. And so what happens in that case is that the likelihood in a mosaic case, where there's only 25% of the cells that have that mutation, these children would have a much lower risk of having the NF1. And it totally depends, their risk depends on the level of mosaicism. And I have many patients who have a level of mosaicism where 1% of the cells in their body have the mutation. And in that case, we would think that their children would have an extremely low risk of getting a mutant gene. So I want to talk for 3 or 4 more minutes about this, and then we'll take any additional questions and then move on to the next part of the program. And so basically here, what I'm showing are the 5 different ways that we can help families with a known NF1 mutation in either the dad or the mom, we can help them to have children that that are not going to have the mutation. So the first one is called preimplantation testing. This is the first way to do this. And so basically what happens is that eggs are retrieved from mom, sperm from dad. In vitro fertilization means that the sperm fertilizes the egg in a test tube, in essence. It's exactly what it is. We grow embryos in a plate. And at the 8-day stage or so, we steal a couple of cells from the placental side of the embryo, not from the baby side, and when we test them for the known mutation that the family has, one of the two parents has. And for those embryos that lack the mutation, then we can implant those into mom. And that gives us a 95% chance of having a baby that does not have the mutation. The 5% risk is that sometimes the way the sequencing done is not doesn't give us the right answers. There's always a tiny chance that the baby still gets NF1. The second way that you can do this is to adopt a baby that doesn't have NF1. Another way is to have, let's say, for example, the father is known to have NF1, as in this case shown here. Another way to do it is to use donor germ cells from another man. And so that would be a possibility. That would also involve in vitro fertilization, of course. One can remain child-free, and that's another way to not have a kid with NF1. But for many families, of course, particularly those that really want to have a family, that's not good for them. And then there is a group of individuals that we see in clinic when we have these discussions and people say, I'm just going to let chance decide. And that's called rolling the dice. That's one way of putting that. So those are some of the ways that we can sort of address this issue of lowering the risk of having NF1 in your baby. So I know I've been yapping a long time here. I think I'll take any additional questions at this point if there are any. Otherwise, we'll move to the next part of the program.
There is a follow-up. Let's see. How do you determine the level of mosaicism? You mentioned patients with 1%.
Yeah. So the way that's done is that you take a blood test out of the arm, a vein from the arm, and we separate out in the blood. We discard the serum. We discard the red blood cells. We keep the white blood cells. Those are the lymphocytes and the granulocytes. And those white blood cells have the same DNA composition as the rest of the body. They're just typical cells. And as might be found as you might find anywhere else. And then what we do is we sequence across the mutation. We know what the mutation is typically going into that situation, and we sequence across the mutation. And the sequencing machine sequences both copies of the gene over and over again, about 300 to 1,000 times. And so we get lots and lots of copies of each one of the NF1 genes, dads, moms, and one of those is going to have a mutation in them. So in the case where there's, say, 10% mosaicism, we would get all of the copies that come off the normal copy of the gene would be normal. And then 90% of the other copies would be normal, and 10% of the copies coming off the sequencer then would show the presence of the mutation. And the computer just calculates up that number, and the testing company warns us. They say, watch out, this is not a 50-50 breakdown of normal versus mutant. And when we see the number go below 45%, it's 45 to 55% is what we call heterozygous. Anything below 45%, we begin to worry, or we begin to suspect this situation of mosaicism. But it can go down to undetectably low. And that's a whole
Thank you, Doctor.
that's a whole nother genetic topic that's really fascinating.
Well, thank you, Dr. Henson. There are two other questions, but I think I'm going to have to ask to hold them until the end of the presentation tonight because we're running a little late. It's 7:30 now. So let's have you go ahead and complete it. And then at the end of the evening, if we have time, we'll get back to the other questions.
Okay. So that's really what I wanted to present to the group, and I think we're ready to move on to the second of the three parts here.
So I would like to introduce you all to Ted and Kelly. Thank you for joining, both of you. Ted is an attorney. He's a founding member of the NF Tennessee Group, which is one of the NF Network member organizations. And Kelly is a stay-at-home mom and a community volunteer. Ted and Kelly and Will, their son, are very active in the NF advocacy when we go to the Hill asking for federal funding. Now we're going to hear from Ted, who's diagnosed with NF1, and Kelly as they navigated the complexities of starting a family. Ted and Kelly carefully weighed their options, including natural conception, embryo selection, and adoption. Thank you so very much for joining us tonight.
Thank you for having
Glad to
us.
be here.
So, I was talking with Kim yesterday as we were preparing for this, and I was explaining that one reason that we decided to be more, I guess, public about our decision to go with utilizing a sperm donor was we wanted to help share the success of our experience, so that people, hopefully to make so that other people can know that see what we consider a success story with our family. We met a young man this summer at an NF picnic here in Tennessee, and he was 18 years old, and he was there with his mother, and he was more profoundly affected by his NF than I am. And the young man's mother was eating with us, and after a while, she said to Kelly, you know, Kelly, I want to ask you a question, and if you want to tell me it's none of my business, that's fine. That won't hurt my feelings. But did you all have concerns about having a child with Ted having NF? And Kelly said, yes, we did have concerns, and ultimately we decided to go with using a medical sperm donor. And this woman then stuck her arm and put her arm around her son and said, "See, son, I told you there are options." And we've always been fairly open with we're open with our family and our son and close friends. But on the way home that evening from the walk, Kelly said, we really should be more open about this, because that young man just looked so relieved when she said that. So that's kind of why we're talking tonight. But one thing I want to make sure that everyone's clear is anything we say tonight, I don't want anything we say tonight to come across as being in any way judgmental of any decisions that anyone makes. We considered all the options. We think they're all very good options. There's no wrong way to have a family. And we had options that other people don't have. Starting off, because I'm the man. I'm the one that's got the NF diagnosis. It's a lot easier to use to go that. Obviously, you can't use a sperm donor if the woman has NF. That's not going to be much of an option for you. And also, it's a very different landscape now with all the treatment options that are available now. That was, at least 10 years ago that we were doing our family planning. Now, with there being 2 FDA-approved drugs that were not really even on the horizon when we started, it's a different landscape. One thing that we did, we met with a family counselor before we used the medical sperm donor. That was something that Kelly's doctor required as her own personal policy before she would perform the procedure. She always requires couples to meet with a family counselor. We did that as a video conference or phone conference with her, and we're so glad we did that. The counselor was really helpful and beneficial, provided a lot of insight, and she encouraged us to be open with the child that would result, about using about the fact that the child was the result of a sperm donor. And she advised us to be open with the child from the very beginning. And we've talked about that with him in as much as you can talk about it with a young child. Um, but he knows that there's someone called the donor. He knows that there's this stuff called DNA that you get a little bit from each of your parents, and he knows that he doesn't have daddy's DNA. Um, and so he knows these things, but we decided to be very open with Will about it. For one reason, we realized we wouldn't ever want him to be unknowingly giving inaccurate information to medical professionals later in life. And so if Will is ever asked by a doctor, you know, does your family have a family history of X on your father's side? Uh, the real actually accurate answer to that question for him is, I don't know. And it's much better for a doctor to hear, I don't, in our opinion, Dr. Henson can correct me if I'm wrong, but in our opinion, it's much better for him to say the accurate answer of I don't know than to be giving inaccurate information based on my family biology. Um, the donors do provide information, at least with the service that we used. Um, we got essentially, it was an online catalog. It's kind of a surreal experience uh, to go through a catalog and essentially shop for the father of your child. Um, I know my sister told me, she said, you know, Ted, women get to choose the father of their child, but men seldom get that opportunity. Uh, and we so that was a really good thing. They do give information to the sperm bank, which is then made available to us, including some family medical history. But they're careful to tell you that that they don't really have a way to verify that. Um, with ours, they wrote each of the donors wrote an essay about why they utilized the why they're sperm donors. Um, we got it narrowed down to two, one that looks a lot like me, and then one that looked so much like me in fact, that when I got home one night, my wife had his picture pulled up on the computer, and I looked and I said, I don't remember having that picture taken. And she said, that's not you. That's one of the donors that I've identified for us to consider. And so we got it narrowed down to that man and then the one that we ended up using. And the one that we ended up using, who looks a lot like me, um, had in his essay wrote this really nice altruistic essay that he donates because it's a way to help people have families, and it was a really sweet, nice essay. And the one that looked exactly like me wrote essentially was to enrich the world, and which sounds a lot like something I would say, but so we decided to go with an altruistic essay, and we're so glad that we did. Um, but by telling Will early on, it's just been a way that it just makes it part of his story, was the family counselor's advice. That just made it part of his story, and it's not some big revelation that hits him when he's 15 or something like that and somehow changes his sense of identity. Um, and, you know, but it's important to know one thing is that, biology has nothing to do with being a parent. So, um, and and that's one thing that we've told Will. Biology has nothing to do with being a family, has nothing to do with being a parent. And we also set a limit of 5 tries. So we were successful with having Will the first attempt. And then after that, we set a limit of 5 tries. After the second one, we said we're going to try. We tried to have 5 more tries after that, and those were not successful. Uh, I don't think that there's any sort of a medical. I don't think your doctors were limiting us on that, but we just decided for ourselves early on. We said, well, for one thing, this is expensive, but more importantly than that, it's just such an emotionally taxing thing to do, to go and go into the doctor's office, get prepared, and then find out it wasn't successful later. It is emotionally taxing. So just for ourselves, we just set that limit. If we had not been successful the first time, I don't know how many times we would have tried, and that's just something each couple has to decide on their own. And if you all saw the pictures, you can tell Will looks a lot like me for what that's worth. He's a lot like me in personality, and you know, he's a part of the family in every way. Uh, and a lot, I gave a talk about a month ago with another NF related group, and the moderator had sent me the questions in advance, and one of the questions was, what would you change? And I'd never really thought about that question before because just sort of my outlook on life, I don't try to think about changing things and what I would like to change. I try not to waste my time with regrets on things that I can't do anything about anyway. But then I thought, so the first thing I thought when I saw the what would you change, I thought, well, I guess I'd change and not have NF. But then after a minute or two, I realized, well, if I didn't have NF, I wouldn't have my son. So I wouldn't want to change having an F, because without having an F, I wouldn't have my son, and I can't imagine him any different than the way he is, and I wouldn't want him to be any different than the way he is. So, Kelly, I mean, this is really more I was telling Kim yesterday, this is really more Kelly's story than mine. I mean, Kelly's the one that had to go through all the procedures and all. I was in the room, but she was the one going through everything. So, Kelly, what would you like to add?
I think that's you covered it. So,
and another reason I told Kim, another reason we wanted to be open with Will about it was if he ever did the like 23andMe or something like that, and later on, and he realized he wasn't genetically related to his cousins on my side, of which he has 11 cousins on my side. I wouldn't want him to think bad things about Kelly. And if he did that and found out that he had 250 half siblings across the country, and he might think, my goodness, I always thought Dad was such a nerd, but golly gee, the ladies clearly disagreed. So it's so again, this is what's worked for us. But Kim, I don't know if you have time if you want us to answer questions now. We're glad to answer any questions that anyone may have, either now or.
Yeah, I think I'm going to run at the end, if you don't mind.
Okay.
Jackson, I am very familiar with you and your family. Nice to have you on the webinar tonight. I do see that Dr. Henson has answered your question, so I hope you look in the chat there. Jackson's question was, what is the likelihood of a severe case of NF1 happening when you pass it down compared to someone who has a very mild case of NF? Dr. Henson, do you want to elaborate on that?
I
I
do. It's a very interesting, it raises this very interesting question or issue about the variation between family member to family member. And so each individual in the family that inherits a mutant copy is likely to have very, very different degree of manifestations, what kinds of tumors, where they are. There might be an optic nerve tumor in one patient, not in the other, et cetera, et cetera. And one of the most fascinating examples of that was in the Netherlands. There was a sperm donor who, this perhaps is too medical, but anyway, there was an individual who had there were a lot of children born from this individual who had the same NF mutation. It was discovered by a doctor in the Netherlands. And the manifestations were just wildly different across those 11 individuals, just not able to, find any sort of, they have this, the same, and whatnot. So the point of that is that you can be severely affected, pass it on to your child, and the child's mildly affected, and vice versa. And so one of the problems with saying, well, I have a mild case, so I think I'm probably okay, having children and not worrying about this is not wise. And because your child could actually be severely affected with it, even though you're not. Now, there's one little caveat to this, because we had brought up this issue of where, not every cell in your body has the mutation. The rare mosaic patient is mildly affected. But when they have a kid who gets the mutation, that mutation is going to be in the first cell, and therefore it will be in every cell in the patient's body. And now we're back to the situation where it's, every cell. So the mosaic person could be mild and their child could be severely affected.
Well, thank you, Dr. Henson. And Jackson, if you have any more questions, please go ahead and put them in the chat box and we'll ask. I'm going to switch to one from Leslie here. Her question is, does pregnancy exacerbate the NF1 symptoms?
Yes. So this is a very well-known problem is that many of the tumors in NF1 accelerate growth during pregnancy. And typically the growth returns to the slower pre-pregnant rate, shall we say. But it's common, for instance, for the burden of skin tumors, for example, to go up fairly significantly during pregnancy. And the tumors that are present in the skin, obviously it's harder to see the other ones, but the ones that are directly visible, the skin tumors will become worse during pregnancy. It's rare that leads to significant medical problems for the mother, but it can.
Thank you, Dr. Henson. There was another question. And it looks like somebody's answering it. Looking for your somebody's wondering what's your contact information, but it looks like somebody from the office is typing to give them an answer. So we'll move on. Unless you have a way that you prefer for people to reach out to you.
To me, you're speaking
Yes,
of?
yes.
Yeah. Well, on there, that slide underneath ours right now, no, the first slide that I had. So my email, are they going to type that in? It's johenson@augusta.edu. That's the best way to reach me. And so JOHENSON@augusta.edu. And I'll read out the office telephone number, which is 706-721-6458. Either of those is perfectly fine.
Okay. Hopefully, Deb or Nan grab that. I did get the cell phone, but I don't have the email. So if one of Deb or Nan, if you've got, then you could type it in there.
Yeah, it's typed into the answer, the whole section from his slide. So it's all there. So anyone can grab it.
Thank you. Thank you, Nan. And thank you, Dr. Henson. The next, there's two questions now here for Ted and Kelly. The first one is thank you for sharing your experience. Do you know if the donor ever asked to meet the child?
So I believe that our donor has stated that the sperm bank that we used had an option for donors who who were open to contact or were not open to contact. Our donor stated that he is open to contact. We have not initiated any type of contact. Kelly has the information which she is saving, and if Will ever at some point expresses an interest in having contact, then we will provide that information for him at that point.
But it's really the family's, our decision to make that contact. So the
Right.
donor, as a donor, he doesn't have a right to say, oh, well, I want to come meet my child. It's not his child. It's our son. And that's just part of that process. But if there's ever a need or a desire for our son to meet him, that is a possibility.
And one thing that I would also just like to say is, as Kelly said, it's our decision, it's our child. Under Tennessee law, and this is a state-specific law, and this was the law at the time that we did it, but if a woman in Tennessee who is married conceives a child with the use of a medical sperm donor with the consent of her husband, then as a legal matter, that child is deemed to be the natural child of the husband. So as a legal matter, Will is my child. We didn't have to do any sort of an adoption or anything like that. So again, if that's something anyone's interested in exploring, you would need to speak with your own attorney in your own state And I haven't checked the law recently, so even if you're in Tennessee, double check it.
Yeah. And here's a question from Jackson. He said, Ted, why did you and your family choose a donor over IVF?
That was a hard decision. I would say that might be one of the hardest decisions we've ever made. There were a lot of reasons. One reason was financial, that it is significantly cheaper to use a donor, at least for us it was. Um, and and again, I don't want this to in any way sound judgmental of anyone, because it's not. As I stressed at the beginning, there's not a wrong way to have a family. But just from our own, you know, just we had just there were some religious reasons for that. Although I should stress that, early on in our marriage, when we first started exploring our family planning options, we met with our priest, and the first thing he said was, we said, these are the options we're considering. And he said, well, before we go any further, I want to make sure that you all understand that this is your decision to make, and whatever decision you make, the church is going to support you in whatever decision you make. And he was emphatic about that. And that was very comforting to us. It was,
I think in the long run, as we met with genetic counselors, we were meeting with our fertility clinic, and it seemed that every time we met, now keep in mind, I was 34, so I'd have been an older mom anyway, getting pregnant, or maybe 33 at the time, but still older. And every time we met, the likelihood of having a successful pregnancy seemed to be going down, and the cost of the procedures seemed to be going up. And that was another thing that we weighed, in addition to just, again, kind of the personal implications that we were feeling of creating a lot of embryos that we knew we weren't going to use. But again, totally a personal choice for each family. And the sperm donor just ended up being the best option for our family, looking at a lot of different options.
And again, that was 12 years ago when we first started exploring. Yeah. It was our son's 9, but it was a several-year process. But we very seriously considered that, and we were able to identify the particular mutation of NF that I have, which was the first step we had to do to determine whether that was even an option for us, as I understand it. So that was something we considered very, very seriously. And I have a friend I have some friends who've done that very successfully with their families.
Well, thank you very much. Now we have another question, and Jackson types in thank you for you guys as well. So this next one, the question is for you, Dr. Henson, regarding identical twins with a spontaneous NF1 mutation. Is it worth testing to see if it is mosaic?
Gotta love questions like this. Now, wait a minute. So in this case, we're asking about genetically identical twins who are affected or not affected. They both have signs of NF1, and they would. So the answer is that they would not be mosaic. So there could be a rare situation, follow me on this, where there's the sperm and the egg that forms the first cell, the zygote. And the way twinning happens is that the next cell division, then one of those daughter cells becomes baby A, and the other daughter cell becomes baby B. Okay, so in that situation, as long as the NF1 mutation is present in the first cell, the identical twins would both have the identical mutation. Now, if the first cell becomes baby A and has an NF mutation, and the first cell didn't, the second cell that's going to become the second baby of the twins doesn't have a mutation, and but you see what I'm driving at here. In other words, if it happens post-zygotically in the second or later cell, you could have an otherwise genetically identical twin that has an F1 and one that doesn't, except for the fact that they're no longer genetically identical because one has a proportion of their cells that has a mutation and the other twin would not. They're no longer genetically identical at that point. So you can get mosaicism in a twin. Good Lord, I can't remember having ever seen such a situation, but you could have mosaicism develop in one member of a twin. You could. Now, if I didn't totally confuse you with that discussion, I would be surprised. But in general, identical twins are going to have the same mutation, except in that strange situation where the second one gets its own mutation.
So that would be very rare then for that to happen.
That'd be a medical case report right there.
Okay.
I start writing that one up the day I see it. But, I mean,
Yeah.
technically, yes, it could happen, except, then somebody, I know the reviewer of the paper would say, well, they're not really identical, doctor, and genetically identical. But, the whole twin thing is, we should do a whole session on twins just for fun. But, even twins rapidly become non-identical. Identical twins, not long after the embryo is beginning to form, are no longer exactly the same. They're largely the same, but not exactly the same. So X inactivation is a good example.
Well, we certainly have had parents come forward and say that they have twins. And I'm thinking of one set of parents in particular where one child was severely affected and the other one was not. And yeah,
But you mean they both had an F1, one severe, one mild?
Yes.
Yeah.
Yes.
So that's another example of what we were talking about a little earlier, where there can be extreme variation from individual to individual in the family. And there's fascinating genetic reasons why that happens. But that's another lecture.
All right. Well, I think that was a very successful webinar. Thank you all very much.
Thank you.
Thank
Thank you.
you. Have a good night.
Good night.